How important is the length of the time to wait after administration of ICG to view the anatomy under near-infrared light? Same, an agreement. This is really very important. What is the minimum effective dose of ICG for fluorescent imaging? The dose is really very low. The vial comes with 25 milligrams. And in some procedures, not in all of them, we can use as much as 1 or 2 milligrams. In some cases, we need to use 3 milliliters, or in some cases, we can also redose the administration of redose the patient. So administrate again ICG. The ICG, it's really very, very safe. There are not so many anaphylactic reaction or allergy reactions. We were reviewing the literature, and in 34 years or 37 years, there was like 17 allergic reactions, and we can provide to you this information. What
Fernando,
yeah.
Sorry to interrupt. I think this is important. You know, we've been doing this group has been doing fluorescent image guided surgery for 10 years. And if any of those on the call of the panelists have seen a serious anaphylactic shock, can you raise your hand or comment on that? Michael? Norihiro, tell us about your case.
Probably we have done thousands of cases for ICG tests for the liver function test. And in my experience, I have experienced only one anaphylactic case.
In 5,000?
Probably. Very, very rare.
Very rare.
How did the patient do, Norihiro? Was he okay?
Yeah, he recovered after the administration of steroids or some kind of support.
Okay.
Takiaki?
Yeah, I worked with Professor Kokudo, so the case will be same case. But this developed not during the fluorescence imaging, but during the liver function estimation before surgery. So the dose of ICG is quite different. We use 0.5 milligram per kilo for the liver function test, and I heard that the adverse reactions due to ICG depends on the dose dependent matter. So I think the risk of the adverse effect during the fluorescence imaging will be smaller than the use for the liver function test.
Thank you. So while you're talking, Takiaki, there is a question from Dr. Saitua, Francisco Saitua. I assume it's from Latin America, asking how deep into the liver can you identify a single nodule using ICG? What's the depth of penetration through the liver tissue?
Yeah, basically the maximum depth will be 5 or 8 millimeters from the liver surfaces. But when there are biliary stasis, congestion of bile juice due to the tumor invading to the Glyconian seeds, then we can detect the location of the tumor located in a more deeply site of the liver in such case.
So the stasis is what matters. How about adding temperature? Do you think that if we could measure temperature in addition to fluorescent signal, we can be even more precise in detecting a lesion?
Yeah, I think, yeah, I agree with you. For example, even when the background liver shows fluorescent signals, then we can change the imaging mode from the normal mode to the kind of SPY mode, enabling the differentiation depending on the fluorescent signals. Then the tumor can be displayed at a very hot spot.
Nice, thank you. Well, I have a question also from Gloria Gonzalez. And she's asking if we are using ICG or can be used to identify a chylus leak, which is something that we don't want to see when we do our esophagectomies. I haven't used it. I had probably 1 or 2 chylus leaks in several, I would say 40, 50 esophagectomies. I have probably 2 of those, 1 every 30. But I do know that in Argentina, Fernando has some experience also coming from Brazil. Michael Bouvet, why don't we go one by one? Do you think for the chylus leak, can we use it to prevent injuring the thoracic duct? Can we use it to identify the leak? Fernando.
Well, it can be, it was described in the literature, if you administrate ICG in one node of the groin or between the fingers of the foot, then if you wait some time and you are performing a neck dissection, you can see, you know, where the thoracic duct is entering the vein there. We had experience, a very nice experience with one patient that was really very sick. He had a nephrectomy and then he had a leak. And he was losing a lot of lymph in the abdominal cavity. He was with a parenteral nutrition. He was operated a second time. The surgeons didn't find the leak. And then we decided, so it was a really very stressful situation because the patient could not recover. So then we came to the team and then we administrated ICG in one node of the groin and we could see exactly where it was leaking. So we could clip the leakage, and you know, the following day the patient was okay. So the answer to your question is yes, it can be, you know, it's really very useful to evaluate leaks.
Michael Bouvet.
Yeah, so it's a good question. And actually, one of our former surgical residents here at UCSD wrote a paper that Fernando was citing there in Annals of Surgical Oncology in 2018. And he did this with John Fay. And John is at the, in Ohio. And they had 6 patients that they did neck dissections on, and they used 2.5 to 5 milligrams of ICG. They injected into the dorsum of the foot 15 minutes before imaging. And then they were able to identify the thoracic duct in the left neck in 5 out of the 6 patients. And they had no injuries to the thoracic duct. So I think that this is a neat indication for the use of ICG, because if you do get a leak from the neck, that can be a really bad problem and difficult for the patient because they have problems with nutrition. And I had one patient who had a leak after a neck dissection, and you know, it was a liter a day. It was amazing. And we had to get interventional radiology to actually inject the cisterna chyli through the abdomen, and it was a big deal. They were able to do it, but it's not easy and not an easy problem to fix. So it's better if we can prevent the injury in the first place by better visualization. So Annals of Surgical Oncology 2018, first author was Chakedis, Chakedis.
Thank you. I don't know if Norihiro or Takiaki have any experience with chylus leaks and you want to comment on that. Norihiro?
I have no comments for additional information.
Yeah, I have had one case of the leakage of the lymph node after the, I think, the colorectal surgery, and the ICG is injected into the mesentery of the colon or jejunum. Then the lymph duct could be identified in that case.
Thank you. Thank you. So Fernando, why don't you keep going with our consensus guidelines? These are very important statements that we achieved consensus.
So this is related what we have described. Fluorescent imaging with and without ICG is useful for surgical quality control. So this, what we described before, you know, we are really increasing the quality control because we are improving the outcome of patient basically. Fluorescent imaging technology has the potential to dramatically alter the way that many surgical procedures are performed. 94% if we refer of agreement. we not only know now that we can improve the visualization of different structures, in some procedures we can improve the outcomes, decrease the leak rate for colorectal procedures, for example. The pillars trials demonstrated that, and there are a couple of papers, randomized papers, that support the use of this technology in order to decrease, for example, the rate of hypocalcemia after thyroidectomy. So then we had more agreement in other statements. Fluorescent imaging is an important tool for the visualization of vital anatomical structures such as arteries and veins. And not only that, we are using that to evaluate the lymph vessels, for example, in lymphedema. In general, fluorescent imaging is an important tool for the visualization of cancerous lesions. There's not all of the cancer that can be seen, but there are different types of malignant cells that can capture the ICG. There is an agreement on that. In general, fluorescent imaging is an important tool for the visualization of sentinel lymph nodes. We describe this, and if we can add something here, is that it is useful for different type of cancers and different types of areas on the body. It is useful for limbs, for melanomas, and also for example, breast cancer or gastric cancer or other areas. There are other statements that we also got an agreement. The agreement was between 70 and 80%.
We decided, Fernando, we decided that consensus is 80% or greater, no?
Well, it's 70% or greater. So these are also agreements.
Okay.
Yeah. So in general, using ICG increases or decreases the overall risk of patients' postoperative care. So decreases the postoperative care. We had an agreement on that, 79%. Using fluorescent technology appreciably increases the overall risk of procedures. Disagree in 77% of the cases. Of the patients, the people that voted. Using ICG appreciably increases the overall direct monetary cost of the procedures. Disagree. So this seems not to be a barrier, because it's not a barrier to start using this technology. And something that Michael mentioned before is that one tower and the ICG is used in different kind of specialties. Not that one tower is going to be used for a specific procedure. Patients undergoing a procedure using fluorescent technology should be provided specific preoperative information about this technology. There was an agreement on that. This consensus. Patient undergoing a procedure using ICG should be provided specific preoperative information about the drug. There is a consensus about that as well. What adverse reactions should be reported to clinicians and patients as most important. We agree that it's really very rare to find a complication related to the dye. Something that we discussed also.
Why don't we put a break?
Yeah.
Fernandito, why don't we put a break here, because I think this is important. I don't tell my patients when I do ICG about the drug, and I don't take a special consent for that either. This is a drug that's been approved by the FDA 60 years ago. Why do we need to create a sense of perception that we are doing a new experiment? Just because we as surgeons woke up 60 years later, we got to tell the patients that we were so dumb that we didn't use it before that and start creating anxiety. Do you ask your patients, Fernando, in Argentina, you tell them about ICG and you get a special consent for that?
We in Argentina, we don't consent for the patient. We explain what we are going to administrate.
We don't. Michael?
No, the only thing I ask is do they have an iodine allergy to iodine or shellfish or contrast? So I do ask that, and usually that's the time when I can tell them we'll probably use a dye during your surgery to help me light up the parathyroid or look at the tumor. And almost universally, they say, fine, anything you can use in the operating room to have a more successful outcome is great. So I kind of mention it to them when I ask them about the allergy. That's what I do in my own practice, but I don't get a separate consent or anything.
Professor Kokudo, how about your experience? Do you get a special consent? Do you make patients aware about the ICG?
Well, ICG is very cheap in Japan, and I have been approved by the social insurance for the use ICG test for liver function test. But for the imaging, it has been long been not approved for the insurance coverage. So during that time, we did it as a clinical trial. So we obtained the informed consent. But recently, it was being approved for the ICG test for the perfusion, tissue perfusion. So now we no longer need. I think we no longer need special specific informed consent for the use of ICG.
Takiaki, how about the cholecystectomy? Do you need a special consent for that, for ICG cholangiography? You are on mute. You're on mute. Mute.
In our hospital, the use of ICG for cholangiography has been approved by the hospital, so we don't use any consent form currently.
Thank you. Okay, Fernando, let's keep going. I think we are getting to the disagreements now, or where we didn't agree.
Yeah. So in general, from a patient standpoint, which of the following is less problematic as a visualization tool during surgery, ICG or blue dye? ICG, we agree in 73%. In general, from a technical standpoint, which of the following is a less problematic visualization tool during surgery, ICG or a blue dye? ICG. And then we have, we didn't reach consensus in this one. The first one is, at what stage of training should doctors be taught about fluorescent imaging, medical school or residency?
So why don't we go one by one? Fernando, when do you think we should start with this?
I believe, if in medical school, we teach students what a CT scan is, what the IOC is, and what a PET-CT is, then we need to explain them as soon as possible what is fluorescent imaging, because this is now part of our armamentarium.
Well, it's been always part, and we learned from Japan, from Japanese surgeons. They've been using this for decades to assess liver function. I mean, any medical student should understand how can you assess liver function. And I don't think that there is a better tool than that. Norihiro?
Yes, so yeah, Japanese medical students are very familiar with ICG as a liver function test. So it would be better to teach them ICGs useful for the imaging as well.
Takiaki?
Yeah, I agree with Professor Kokudo.
Michael?
Oh, I vote for medical school. I mean, we have medical students here, and they're scrub on all the cases, and they're very adaptable for new technology, and you're just teaching them about anatomy. They love it. So I don't see.
I think that I need to talk to Rick Manor. I think we were all a little bit drunk and had too much German beer when we voted on this one.
Yeah.
Because it sounds like we all agree on this, that it should be studied as early as possible in medical school. We think it's a great tool for our residents to identify structures, to identify the anatomy, to understand how the liver works, et cetera, et cetera. So we all agree on that. I don't see any comments from the chat room, but if you guys want to vote on that, next time we're going to get them to vote. And what's the next one, Fernando, we didn't agree on?
Patients undergoing a procedure using ICG should generally be asked to give written consent. There are parts that vote yes and the other one no.
Yeah, so, you know, I personally don't think that we should get consent for something that is safe and it's been proven to, you know, by regulating agencies 60 years ago. Since many surgeons perceive that they have exposure, probably that's what created the uncertainty when voting on this item. There are a couple of other questions on the chat room, and one of those is from Gloria talking about bone cancer lung metastases. Do we know if ICG has been used to identify osteosarcomas or metastatic disease to the bone? Takiaki, any experience with bone metastases in ICG?
No, I don't have any experiences, but technically it may be possible because by using the EPR effect. But I think it's very difficult to differentiate a small uptake of ICG and background fluorescence signals.
Norihiro.
No more comments.
Michael?
No, I think, you know, one thing I could just say in general, using ICG for tumor imaging is very different than for gallbladder or assessing perfusion. And for instance, most people, surgeons will give a much higher dose of ICG and they infuse it at least 24 or 48 hours before the surgery. And then some tumors take it up quite nicely. There was a paper from Stanford, I think it was, where they used ICG for Whipple's and pancreas, but you give it in a different way than we do for perfusion. So just to make the audience aware, it's slightly different. And I haven't seen any data on bone metastasis, but it sure would be interesting to look at.
Fernando, you've done a lot of cancer surgery in Argentina at the University Hospital. Any comments on metastatic disease?
The only what I would like to add is that ICG is not really specific for a specific tumor. So the only thing that is specific for a tumor are antibodies that are tagged to a specific dye. This is not approved yet, but what we have seen in cancer, in some type of cancer, in adrenal tumors, for example, is that it depends on the vascularization of the tumors, or for example, in insulinomas. So you have an arterial phase and then a venous phase, and then you can differentiate the tumor from the tissue, because, you know, the normal tissue clears quickly or quickly the ICG compared to the tumors. But we cannot say in general in oncology that it's specific for one tumor. It depends on the vascularization of the tumor.
Yeah, I agree. And that answers a question that was asked by Dr. Delgado regarding the pathophysiology, how ICG adheres to tumor cells. You need to create an antibody to the tumor cell, and then you need to tag the ICG to the antibody. And that's how you can identify the tumor cells. But ICG alone, unless it has a carrier, will not make it to the tumor cells specifically. Similarly, we have a question from Dr. Douglas asking if ICG can be used for non-invasive bladder cancer detection. To be honest, that is a very ultra-specific question, I think, for this group. I don't know if anyone has experience with that. Raise your hand. But I haven't read anything in this regard. Natalia Cano asks again if the biliary anatomy can be obscured in patients that are obese, and the answer is yes. if you look at the prospective randomized controlled trial that this group published in the Annals of Surgery, you will see that with ICG, you can significantly, not significantly, but you can see much better the biliary anatomy, even in the obese, but it's not highly significant as it is in the non-obese. So definitely fatty tissue, inflammatory tissue affects the penetration of the near-infrared energy to activate the ICG and make it more visible to the human eye. Ladies and gentlemen, we are getting to the top of the hour, and I don't want to take your time. I know that in Japan, in the Asian Pacific region, they have to go to the OR and to their meetings. We on the East Coast want to go to sleep. Michael Bouvet probably wants to have dinner pretty soon. So why don't we get some closing remarks from the group, starting with Takeaki on the far right of the screen.
Yeah, thank you very much for joining in this event. And I believe that fluorescent imaging is change the surgery. So please use in your each region, and please send a report. We need more and more reports on the efficacy and the limitation of fluorescent imaging. Thank you very much.
Professor Kokuro.
Yeah, thank you very much for this opportunity. And I was very excited to join. And as I remember, we could not answer all questions, every questions. And as Takashi said, ICG is still new thing. So we'll have more new findings in the future. So I am very excited to see the future development. Thank you.
Thank you. Michael?
Yeah, thanks, Raul, and thanks for keeping it so exciting and interesting. And you're such a great host. But I'm very excited about fluorescence imaging and the future. I think it's really all about improving patient outcomes and reducing complications. And I think that's really what our society is really all about. So improving patient care. And I think we're learning more and more about the technology every day. And I really enjoy these sort of webinars where we can all share our information. Thank you.
Well, I can say, before I let Fernando close as our president of this society, I can say as a Secretary Treasurer that our economy is strong thanks to the support of our corporate council. Again, Medtronic, Storz, Stryker, Olympus, and a giant diagnostic green support to this society to carry out all this research work. Thank you, all of you for our support. We hope that as vaccines are coming through, we'll be able to have our face-to-face meeting September 2021 here in Florida again. I'm going to keep you posted where and when with exact date. Next weekend, we have our Advisory Council virtual annual meeting where we're going to talk about all this. Please visit our website, become a member, send us videos, send us material, get involved in the society. And thank you, Fernando, for allowing me to interrupt you all night long. And why don't you close the evening as the president of ISFGS?
No, thank you very much, everybody, for being here. This has been really a teamwork. The only comments that I want to say is that this is now we have a technology that allow us to see things that we couldn't see before, and for surgery, this is really very important because this is safety for patients. It has demonstrated that improved outcomes in many surgical procedures. Also that, again, all the platforms now are coming with this technology. And I consider that it's really very important that in many surgical procedures, this should be used routinely. And in a couple of years, I'm sure that it's going to become a standard of care for most of the procedures. This is not experimental anymore. There is a lot of literature out there that really supports the technology. And please, Raul, close.
Well, I want to thank also behind the scenes Alejandra Marichello and Electra McDermott, our executive director, that are working avidly in putting all these webinars together. I think you're going to see tons of webinars coming up. We're doing them in Spanish, we're doing it in English, we're doing it in all languages. We recently participated with one of our sister societies, which is the Japanese Societies of Fluorescent Guided Surgery. We're doing it monthly with Fernando, with Latin America. So it's a growing field. Thank you, everyone. Stay safe, be healthy, and hope to see you soon again. Good night.
Thank you.
Right. Thank you.